So I actually have the honor and privilege to try to take the other view that there is no standard second-line therapy for HCC, and I'm really going again one of the world experts in this disease. So that's a tough task. But for the record, to go back on your notion, Lancet is a great journal, but it's not New England Journal of Medicine, as we learned from Jordan Berlin. And there are all reasons why you don't make it to the upper tier. So the challenge, again, Dr. Abou-Alfa went through the second-line regimens, and regorafenib is indeed positive in this study. And this study, unlike others, did show benefit following sorafenib failure. Now, I don't want to actually spend time talking myself. I'm just going to refer to Dr. Abou-Alfa's piece and Dr. Eldika, who's here. So we got really two of the experts in the field who were arguing against or having some reflections about why regorafenib, the resource trial, is actually positive, but there are a lot of questions about why we cannot just adamantly say that this is a standard. And again, this is Dr. Abou-Alfa. I'm using his own words here, and I feel bad about that. But these are some of the points, not to belabor upon them, but at least 400 milligrams dosing of sorafenib is suggestive of pre-selection of patients. So essentially we're saying here we've highly selected patients who eventually went on regorafenib. Patients were allowed to be randomly assigned on the trial within up to 10 weeks from last sorafenib dose. So there was, a question mark about the wait time. Then third, in what context did patients receive sorafenib? Is it adjuvant, part of transarterial chemoembolization? Some of these questions will come about, but these are some of the questions, again, that were brought about Dr. Abou-Alfa and Dr. Eldika. So it is unknown whether sorafenib sets the stage for regorafenib action by inducing specific alterations, so unknown. For now, we await the key details, and hopefully we'll get more of those, but many questions remain unanswered. And molecular biomarkers and clinical correlation studies are urgently needed to help answer them. That's not going to happen. So just to add to the overall confusion, now this study was regorafenib followed sorafenib failure, and now we hear that an agent called lenvatinib is actually at least non-inferior, maybe has some hints of interesting activity versus sorafenib and less toxicity, so they may change the landscape of how we treat patients in the first line. And that, if that becomes a standard for first line, how do you interpret the results of the resource study? Just to add a little bit more to the confusion. Well, as we know, again, this is a new world, the world of immune therapy. And there's so much excitement about immune therapy, we think we're going to cure cancer across the board. So is it in HCC a reality or just too soon to tell? And how that may end up actually confusing even further the picture for us in HCC. Again, multiple trials going on in HCC. But I'm going to present some of the data actually that was already available, that's already available to us. This is from Dr. El-Khoueiri, who presented phase 1/2 safety and anti-tumor activity of Nivolumab in patients with advanced HCC, included patients with uninfected, HCV-infected, HPV-infected, etc. Turns out it doesn't matter if they were infected or not. And these are the characteristics of the patients. Notice that about 80% of those patients actually received 70 to 80% prior systemic therapy, including sorafenib. So that's a sorafenib followed by immune therapy for most patients. And this was actually a major presentation at ASCO, and you can see the response rate was about 15%. And this is waterfall plot. Some of the responses are pretty impressive, but the response rate was actually 15%. And the survival, depending whether the sorafenib naive or not, was about between 14 and 15 months for a highly selected patient population. So that's not far off from, say, the first-line sorafenib study, the phase 2 randomized study that Dr. Abou-Alfa published in JCO. Then we look at the expansion phase with patients again. This now, because people got excited about this a little bit more, so less of them were actually pre-exposed to sorafenib. and more were essentially, there were 60 to 70%, but still a sizable percent of patients were pre-exposed to sorafenib. So that's mostly a second-line therapy, and you can look at the objective response rates. Actually, most patients did not respond. In fact, the objective response rate remained stable around 16% with these immunotherapy regimens. Now, one can argue that you need to actually do more blockade with CTLA-4 plus PD-1, et cetera, multiple other strategies to do that. But nonetheless, I mean, these are interesting, but not overwhelming. And this is the survival, essentially, at 6 months with the immunotherapy regimen. So what led to this lenvatinib phase 3 study was a Japanese study, actually a little obscure study, but that was essentially the study that sets the stage for taking lenvatinib eventually to phase 3. And this was a study that had about 25% of the patients who had prior exposure to therapy and ended up essentially receiving lenvatinib mostly in the first line. Pretty impressive results for a phase 2 study. Time to tumor progression was 7.4 months, median overall survival 18.7 months, and a partial response rate of 37%. Now, mind you that in the phase 3 study, it looked like it was non-inferior to sorafenib. We don't have the actual results. Seriously doubt that it's going to be a response rate of 37%. The point that's being made here will be actually shown in the next slide. So I'm going to show you actually the waterfall plots for lenvatinib versus nivolumab. Actually, the interesting part here, I did a blinded study for 2 of our fellows. So I don't know how much that counts scientifically. But I told them to pick the one they thought was a waterfall plot for lenvatinib phase 2 versus nivolumab for dose escalation. So which one do you think they picked, thinking that that was the magic of immune therapy? Of course, the one that actually was a lenvatinib waterfall plot. This is nivolumab. And so that's a sobering moment a little bit as we're moving to all these phase 3s with a lot of excitement about what we found in the phase 2 and phase 3. Now, so where does all this leave us? So first question is, where does the lenvatinib first-line study leave us? Will it displace sorafenib? And if so how do we end up interpreting the complicated and so far partial results of resource? Where will immunotherapy fall in the mix? Is it going to confuse the picture even further? A number of large studies are underway to examine their role in first and second line. So my point is that the landscape in first-line treatment of HCC is very fluid at this time, and you can argue the same for second line. So I'd say, we all stay calm and remain vigilant. There's a lot that may change in this landscape, and we may see actually a lot more fluidity than we think. And my conclusion actually is there is no standard second-line therapy for HCC. It remains very fluid to understand what's going to happen in first-line, second-line, immunotherapy, all these things coming in the mix. Thank you.